Hi, I'm Jerry Radish. I'm here, and just luckily across from me is my old friend Mike Morrow, curiously enough.
Fantastic.
What are you
How
doing here? We're at a meeting, as always. The biggest, hottest topic has been treatment-free remission. Because in the old days, we thought people were going to be on these drugs forever, and we were kind of shocked when, in fact, many of them could discontinue therapy and actually stay in a remission without getting any more therapy at all. Where is your level and your enthusiameter about pushing people to get to TFR and then suggesting TFR? What kind of patients do you want to do this? What kind of patients are you a little reluctant even when they're pushing you to do it? What does that discussion sound like?
I'm always really careful to phrase TFR as a choice. I don't know if it's a necessity. I think ultimately we may start to rephrase it, but I really think it's a beautiful choice that we've been able to develop with the science that's been developed, the bravery of the first patients that went through early TFR trials, and the data that we have available that really shows us that it can be done. Retreatment success is high. We don't have instability generally, so but we have to be careful. And I think we've done it in research, and we've done it in certain subsets of patients. We've sort of moved the bar slowly back to being a little bit more liberal or more permissive on who it can take place in. But my take is I carefully monitor the patients, and when their circumstances are such that TFR is inappropriate, then we offer it as an option. Some people walk in the door in 2018, knowing I have CML or I've been diagnosed with CML. Just how long am I going to need to be on the drug? Whereas people who started many, many years ago say, you're going to have to pry it out of my hands because they don't want to lose it. So the spectrum is broad, I think, on the way patients view it. But I think it's our job to offer it as a choice, to be really careful about it. And I know you've driven the guidelines, and now it's in our NCC and US guidelines, so to help people. But I think it's a new era now that it's blessed, it's sanctioned.
So what are your the Mike Morrow guidelines to patients that you would think about doing this?
Being in an NCCN center, I like to endorse the written law as it comes.
Yeah,
because I believe
we are benevolent dictators.
I think it's top minds getting together and saying what's the most reasonable data that we have to tell us how this should be done, and I think we still have some debate on just how long someone should be in remission, just how deep a remission is absolutely necessary. But I think the general trends are patients who have had essentially smooth movement into deeper remission, have had a lengthy deep remission. And, and honestly, when the push comes to shove, talk to a patient in the office and they say, well, when could I stop? And you tell them 2 years of deep remission may be enough, but maybe 3 years would be better depending on what their treatment is. Most people take the conservative approach and say, well, like an investment, let's let the bond mature a little bit more. I want to get the most interest. I want to boost my odds. So I use the guidelines as they are and then adjust it to the patient. And often they may opt to be a little bit more conservative. I would definitely err on the side of not being too liberal and bending the rules. I think sometimes a very detailed molecular response, you can be a little bit more interpretive with regards to MR4 and below. But and I'm intrigued. I think in the future we have to answer the question, what about people who have some degree of resistance? What about some small data that's been published on patients who actually had pretty significant resistance, but then who actually went into the fold and had a deep molecular remission? Could we stop in them? I think time will tell.
So when patients embark on this discontinuation journey, I'm sure most of them think, well, this is going to be great. This is going to be like what could happen, right? So what type of things do you warn them about in regards to this issue of withdrawal symptoms, the issue of needing to get monitored, the anxiety of awaiting your PCR results, and that issue?
Well, I tell them if they live in Seattle, they could get results, same day, next day. But they're tough luck. They live in New York, so they got to have it longer. But I absolutely, I think the first point is it's a choice, and that it may raise anxiety. I definitely go over the fitness as well. If CML treatment's a marathon, the TFR is kind of a half marathon or an Ironman of some kind, where you're needing to have PCR testing every month and then every 6 weeks for a long period of time. So that's the key elements have to be easily done. And I prepare them for the withdrawal syndrome. I think it's hard to predict. It scares people, but when you tell them best available data that it generally should be self-limited. It's generally not high-grade toxicities. It might make them feel like they want to go back on drug or they need some kind of therapy to offset it. But I think as we do this more and understand that better, hopefully we'll have better solutions for it. But all those things need to be covered so the patient's not caught off guard, especially the anxiety and the stress part. That's why I make it a choice and say, when you're ready, I've given you the green light, you tell me, and then the patient it's on their own terms.
So what do you do if someone comes in and they really want to get to the TFR status, but their molecular response just hasn't been deep enough? It's pretty good, but like, what can you do? Are you really anxious to get them on a trial, given that there's a benefit that they might get the DMR, but you don't know that having to really push on someone to get them there is the same as someone who just went there by themselves, right, on TKI, and the toxicity that you may have to do to give them to get that potential benefit. How does that discussion look in your space?
So I think it kind of goes back to the patient decision and the choice, like goals of therapy. Younger patient is pushing for, not having lifelong therapy. I'm going to be motivated to do whatever I can to optimize their drug dose, maybe a switch, maybe a trial to get them to deep MR. As the treatment goals shift a little bit, people may be okay with staying in a relatively good, somewhere between an MMR and an MR4, or something that may not look exactly like a TFR as possible, but a good molecular remission. I'm a clinical trialist. I'm going to try to have people move into safe combination therapies, or maybe looking forward to the fact that if people are good enough and they try TFR and they don't have success, I think that's an untapped area or an area of unmet need. Research into second TFR, because everyone might not make it, but I would definitely encourage people who are motivated and who want to achieve TFR. They need to meet the criteria, based on current. So I wouldn't bend the rules and start stopping drug in people who are close. I would encourage them to stay the course. Hopefully they're on a TKI that's safe and they're tolerating pretty well. And as long as there isn't the three criteria that I use to tell people when you should think about TFR is if you have a drug that you're on and there's toxicity you're having, you gotta try to stop it. You're worried about a toxicity that's coming or could come on the TKI you're on, or you're just really motivated. So, the push to get someone into deep molecular remission may be stronger in where people are using drugs where there could be potential risk if they use it for long periods of time. So that also plays in.
Great, that's great. Thank you very much. We'll do this again soon.